Hi everyone, this is Gabby. Isela and I will be presenting on Duchenne muscular dystrophy. Duchenne muscular dystrophy, otherwise known as DMD, is a severe progressive neuromuscular disorder that arises from a genetic mutation. It is under the umbrella category of muscular dystrophy, but it is the most severe type. It is rapidly progressive and results in muscle degeneration and atrophy. It is one of the most common X-linked disorders, so we see this mainly in males, and it is characterized by early delays in gross motor development, and it has a significant impact on quality of life and engagement occupations, which we'll dive into very shortly. Since DMD is an X-linked trait, females can be carriers, but they are typically asymptomatic and experience much milder symptoms, so we'll be focusing mainly on the male presentation. Key features of DMD are gross motor delay, muscle weakening, loss of ambulation, and other symptoms that affect other systems. So starting with gross motor delay, this is first noticeable between 1 to 3 years old, and some of the hallmark signs are delays in walking, ability to sit independently and stand independently. When they are able to walk, we can see waddling gait patterns, frequent falls, difficulty running, climbing stairs, jumping. Muscle weakness, clients with DMD gain strength and motor skills until around 6 years old, and then we see a drop-off where rapid deterioration in muscles begins. There are signs of muscle hypertrophy in the calves, which is a sign of proximal weakness. And then overall, we see global muscle weakness starting in the lower extremities and then moving into the upper limbs and the trunk and neck. And positive Gowers sign is a sign of muscular or DMD. And you can see it in the picture here where they ask the child to stand up, and when they stand, they have to use their hands to push them up and assist in standing. With the severity of muscle weakness increasing with age, we see a median age of loss of ambulation around 12 years old, with clients being wheelchair bound by 8 to 14 years old, with again the median age being around 12 years old. Language delay is also very common, intellectual disabilities, ADHD, ASD, and there's also a lot of psychosocial implications that we will get to later on in the presentation. There are quite a bit of comorbidities that DMD clients are susceptible to, one being scoliosis, and this is often a result of being wheelchair bound. Contractures are also a result of being wheelchair bound and a lack of mobilization, and these are common at the hip, knee, ankle, and iliotibial bands. Cardiomyopathy is a very prevalent one, which can start as early as 10 years old, and it is present in most patients over 18 years old. And this is due to physical inactivity, deconditioning where the heart chambers enlarge and the walls thin. And then respiratory decline is also a very common symptom and comorbidity of DMD that presents late teens to early 20s, and patients often need ventilation as early as 20 years old. And obstructive sleep apnea is also a common comorbidity. And another note on respiratory decline, lung capacity increases until 12 years old and decreases by 4 to 8% per year. So this just speaks volumes to how much muscular deterioration we're seeing whole body, whole system wide. Now getting into the etiology, DMD is caused by a mutation of the DMD gene, which is located on the X chromosome, and why it is expressed much more prevalently in males. And the mutation causes a deficiency of the protein dystrophin, and dystrophin is responsible for maintaining the structure of muscle cell membranes. So this affects skeletal, cardiac muscles, and brain cells, which is also why we see intellectual disabilities. And the muscle fibers are replaced by adipose and fibrotic tissue, and this explains the muscle weakness. So in general, 70% of the cases are inherited and 30% are random mutations, and we typically, or the physicians typically diagnose DMD by 4 years old. So DMD is considered rare, but it is one of the most common genetic disorders affecting males. Global prevalence in Europe, North America, Asia, and Africa, studies show that there are 7.1 cases per 100,000 males and 2.8 cases per 100,000 males and females. the most cases being in North America with 5.1 cases per 100,000 males and females, and the lowest in this particular study being in Africa at 1.7 cases per 100,000 males and females. The two most prevalent symptoms interfering with occupations are global muscle weakness and cognitive function. Muscle weakness affects daily self-care tasks, mobility, functional ambulation, transfers, fine motor skills, gross motor skills, and communication. So if you can imagine like total muscle body weakness, basically all of your ADLs are affected. So bathing, toileting, dressing, feeding, personal hygiene, grooming, functional mobility, and a lot of our IADLs are also affected. So community mobility, meal preparation, being able to, use a knife to cut the food, personal care device management. So taking care in this case would be wheelchair or any other assisted devices the client may have, formal education participation. So being able to hold a pencil, being able to communicate with your classmates, with your teacher, leisure participation, engaging in if they want to play sports or any sort of hobbies, and social participation. So navigating the spaces and being able to play with your peers, with your family, things of that nature. And similar to what we said with the key features, cognitive impairments lead to intellectual disabilities, challenges with attention, and language delays, which impacts the client's ability to participate in school, make friends, play with family. Cognitive impairments also affect the ability to sequence actions safely at home and in the community. So this is affecting dressing, bathing, meal preparation, and community mobility, to name a few. These are the most common medical management medications and treatments that DMD clients are given. However, corticosteroids are the most researched and common medication used to treat the symptom of DMD. So corticosteroids are kind of like the gold standard for DMD. The most common corticosteroids are prednisone and deflazacort, and they are used to slow the decline of muscle strength, cardiovascular and respiratory function. So it's used to help with mobility and reduce the complications affecting the lungs, heart, and musculoskeletal system. It reduces the risk of scoliosis, and some effects of that are that long-term steroid use leads to decreased bone density, so there's increased incidence of fractures. It can also increase weight gain and hypertension, and stunted growth is also very common on corticosteroids. Ventilation is also a very common treatment. The two most common types are tracheotomy and nocturnal non-invasive intermittent positive pressure ventilation, or NIPPV. This provides symptom relief of the decrease in lung function, and it also improves life expectancy. But during treatment, we need to be able to watch for lines, watch for the trach, and we also need to be wary that having ventilation increases the risk to respiratory infections. And lastly, muscle relaxants are less common, but they are used to treat contractures. And as clinicians, we need to be aware that use of muscle relaxants increase the risk to malignant hypothermia-like reactions, which is a life-threatening condition that is caused by rapid and uncontrolled rise in body temperature. And so we need to be aware that this can happen when we are treating our patients.
So what is the role of occupational therapy? Well, we can promote functional independence and maximize function through using orthotics to preserve range of motion, educating the family on stretches and positioning. We can help limit joint deformity. We can modify activities and simplify tasks, recommend assistive equipment, address psychosocial support, and also address functional mobility. So regarding our client that will be presented in future slides, the occupational therapist will begin by addressing limited range of motion interfering with the occupation of dressing, and the OT will apply the biomechanical frame of reference and compensatory frame of reference. To address self-regulation skills related to loss of ambulation interfering with occupation of social participation, OT will apply the occupational adaptation frame of reference and cognitive behavioral frame of reference. Other therapies for individuals with DMD include physical therapy. Physical therapists are able to provide regular exercise to slow the progression of muscle weakness, improve cardiovascular function, reduce the severity of contractures, and improve quality of life. Psychologists can also be involved. Patients with DMD are at elevated risk of developing psychiatric disorders, including attention deficit and hyperactivity disorder, autism spectrum disorder, obsessive compulsive disorder, anxiety, and depression. They can work closely to address cognitive and behavioral comorbidities that are associated with the diagnosis of DMD. And lastly, there's respiratory care, which includes respiratory therapy. Respiratory complications are common in individuals with DMD due to the relation of the inspiratory and expiratory muscle weakness. And routine monitoring of respiratory function is vital and should start as early as diagnosis and can be routinely done and should occur every 6 to 12 months. Moving on to the prognosis. So the common cause of death among individuals with DMD include respiratory and cardiac failure. The median life expectancy is under 30 years of age, and there is currently no cure for individuals with DMD. So as of now, the treatment efforts focus on managing symptoms and complications. However, individuals with DMD are living longer due to the advancements in care over the years, and this includes improved access to ventilatory support, the development of molecular and genetic testing, and the broader dissemination of clinical guidelines and research. Included in the prognosis is the cost burden, and this increases as DMD progresses. So it's important to note the indirect costs can significantly impact finances and should be included in care and financial planning across systems. It's also important to note the psychosocial impact. This article by Bever describes the impact on caregivers and families that have a loved one with DMD. And one family stated, "It's just hard, you know. Our family and friends don't understand what our life is like, and they're not in it as much as we'd like them to be. But we still find ways to have a good life." Now looking at the psychosocial implications for the client and the family. So psychosocial impacts can include the progression of symptoms and the clinical manifestation of DMD, social barriers, personal growth within the individual, adaptation, and how much or how little family support there is. With the progression of the disease, the client can be challenged with feelings of embarrassment, sadness, and frustration. And this is why a support system is important when one is going through the diagnosis of DMD. So it has been seen that not only individuals cope with the challenges DMD presents, but their families are also involved as well. And this is why a family support system is significant, and this overall improves quality of life for individuals with DMD. With that being said, caregivers also rely on emotional, social, and practical support when their loved one has been diagnosed with DMD or when they are taking care of someone with DMD. Patients and family have been reported to cope with the challenges DMD presents by living in the moment. Our client case study is on Ricardo Johnson. Ricardo Johnson is a 12-year-old Indian American who was diagnosed with DMD at age 4. His parents became concerned when they observed that he was unable to walk, run, climb, or jump at the park like other kids his age. They also noticed he was falling frequently and his calves appeared larger than normal. He currently lives with his parents, Michael and Sasha, and his older brother, Raphael, in a one-story home located in Los Angeles, California. The family attends weekly church services and values family mealtime and community gatherings. Ricardo attends a public elementary school and currently receives outpatient pediatric OT services twice weekly at a regional children's rehabilitation center. As the disease progressed, he lost the ability to ambulate and currently uses a powered wheelchair for mobility. He also requires assistance with weight shifting and posture correction to prevent pressure sores. Ricardo is a bright boy demonstrating the following strengths and preferences. He enjoys reading, playing video games, watching sports, spending time with friends, and thrives with a structured routine. Due to his condition of DMD, he demonstrates the following deficits: global muscle weakness in the lower extremities, upper extremities, and trunk, difficulty with ambulation, difficulty maintaining posture and balance, limited mobility within the home and the environment, and is struggling with self-regulation skills. Ricardo is unable to spend time with his friends and family due to feeling frustrated, embarrassed, and sad. He states, "I'm not able to move like I used to." Ricardo has difficulty dressing himself independently due to limited joint mobility and muscle weakness resulting from his diagnosis of DMD. He's unable to effectively position his body, bend, reach, or manipulate clothing, and he struggles to coordinate his extremities to hold and put on clothing items. In terms of social participation, Ricardo experiences challenges with orienting himself towards others, turning to engage in his conversation, navigating social situations, and regulating his emotions. He currently uses a powered wheelchair for mobility and struggles to engage in activities with his family and friends. First occupation we will focus on is upper and lower body dressing, and this is an activity of daily living. Some client factors involved are decreased joint mobility, joint stability, muscle power, muscle tone, muscle endurance, and control of voluntary movement. Some performance skills are positions, bends, reaches, manipulates, and coordinates. The second occupation will be spending time with friends and family, which is a part of social participation. Community participation, family participation, and friendships. Some client factors involve temperament and personality, emotional, decreased joint mobility, and structures related to movement. Performance skills include places self, turns towards, navigates, and regulates. That concludes our presentation. Here are our references. Thank you.